Good morning, everybody. Thanks for inviting me. Even though you didn't invite me, you invited my boss. It's okay. I took care of that. But anyhow, what I wanted to talk to you today, whenever you're looking at a paper, they talk about the epidemiology. And that's what I'm going to talk about. What do we see in the incarcerated population? And talk to you a little bit about how a person makes their way through the medical care in the prison system. Oops, I'm sorry. So this is Commissioner Coop is our commissioner. He is the secretarial level officer who's responsible for all the care feeding of the approximately 22,000 people who are in the system. I want to spend a little bit of time talking about the different levels in the incarcerated population. Now I'm going to go backwards. What everybody thinks of for a prison is what we call level 5. A level 5 prison is from moderate to maximum security. Below that, we have a level 4, which is the beginning to move people out of the prison system and into the community. Level 5 is the classic Bureau of Prisons. Level 4 and below belong to our community correctional system. We also have levels 1, 2, and 3, which are really people who are out of the system and do not get their medical care through what I'm going to talk about this morning. So we're talking about, for here, level 4 and level 5, okay? That makes sense to everybody. Our overall budget, $297 million. Medicine takes the majority of that. And we'll talk about what it takes to contract for our medical services, our behavioral services, and we have a third contract for pharmaceutical services. Just to give you an example of the amount of care that it takes, our pharmaceutical contract is $1.2 million a month. Okay? That is a lot of money to pay for medications. Okay. So we manage all of the health, as I had mentioned, the medical services, the behavioral health, and our contractor for both of those are Connections Community Support Services, and they do an extraordinarily good job to take care of our people. What we attempt to do is to approximate the medical care that an incarcerated person would be able to get were they not incarcerated. Now, when you get outside the walls of the prison, there's commercial insurance and there is Medicaid. The majority of our folks are would be Medicaid eligible. We'll talk a little bit about one of our challenges when they come into the prison system. But what we try to do within the security of public safety is to approximate as closely as possible the care that a person would receive, a Medicaid eligible person would receive were they not incarcerated. The one difference that our system is different from most states is that most states have jails which are county run that when people are arrested, they go to the county jail, and then if they are sentenced after they go to court, they would come into the prison. There are 5 unified systems in the United States. We're one of them, where both our detentioners and our sentenced prisoners all are housed in the same building. Now, for a whole lot of legal reasons, we keep them separate, which is actually a difficult thing to do at times. When they come to the medical unit, you would think that they could talk to each other. We have to spend a significant amount of time keeping the detentioners, those who have not gone into court, from the sentenced population, which is a major issue. Somehow, I haven't figured this out. I managed to send it backwards.
Oh, that's okay. I always click on this after click.
Okay. Thank you. So talking about our level 5. Now, level 5 is the prison that everybody usually thinks of. They are sentenced. They spend from 1 year to our life people. And this is the breakout between the male and the female. We have one female prison, that's Baylor, up in Newcastle. And the 5,000 males are spread between Sussex, which is down Sussex County, Vaughan, which is Newcastle, and Howard Young, which is also in Newcastle. Having said that, there's a number of articles that are out in the system, out in the publications now, talking about how the female population has been the fastest growing. And actually, that is the truth. When I first came to the department 4 years ago, we have almost doubled the number of women who are serving long-term sentences. The race, I'm not sure everybody can see it. The small is the Asian Pacific Islanders. The red is the African American. I'm not sure what the purple is. And the very dark purple is Caucasians. By ethnic, we break out the Hispanic versus the non-Hispanic and the unknown. The populations that are changing here is the African American population basically is very stable. The Asian population is increasing all the time, and we're really not sure what that means, where it's coming from. These are the number of admissions that we have and the number of releases. So you can see that the numbers are relatively stable, but most of our prisons are relatively overcrowded for the number of offenders that they were built for, particularly when you talk about Howard Young and Vaughan. The level 4 are the step-down units. Many of the level 4 have substance use programs and a work release program as part of the substance use treatment. The whole idea is that we're trying to flow them from the level 5 to the level 4, get them the substance use treatment, and then in the last phase of their substance use treatment, to get them into a work release program. That's great until you realize that the unemployment in the state is tremendously difficult to get jobs for these folks. And they're jobs that we get them into for the last 90 days with the hope that they are able to continue that job after they are released. We have a very difficult time finding those jobs for those offenders. Our probation and parole are the levels 1, 2, and 3, which the offenders are then released from our custody. Then they show up at our probation and parole offices periodically. Some folks come in 2, 3 times a week. Some people really only have to make contact twice a year or 3 times a year. So these are admissions, 15,000 to the probation and parole, and the releases is another 15,000. This is a very large, difficult population to keep track of, particularly those people who have substance use disorders and have been ordered by the court to have some kind of monitoring. Very difficult to keep track of. So, our discharge planning. Now, let me explain one of the things that happens. From the very first time they come into the facility, an offender goes through what we call an intake screening. In the intake screening, we determine what kind of medical behavioral health services they're going to require. From that intake screening, we then set them up for the folks who have chronic illnesses. They're seen every 90 days. We get them on their medication. We validate with the pharmacies that they have been getting their medication that they are actually on these medicines that they tell us, and then we continue the medicines. One of the things that the statistics don't show is our number of people who are over the age of 60, which is roughly 2% of our population. And that 2% of our population can actually eat up close to 40% of our costs, because those folks have a lot of just typical medical needs. We have, at the present time, 5 people who are getting outpatient chemotherapy medications. Those 5 people and their chemotherapy cost us $200,000 a month. So those small number of people impact us greatly. We have a number of people who have HIV disease. On any particular time, we run about 90 people who have HIV disease, and at our current cost, it costs us somewhere about $24,000 a month per offender to treat their HIV disease. Everybody knows the story about the hepatitis C. At any one time, well, right now we have 264 people who have hepatitis C. With the costs of our hepatitis C, we're able to treat approximately 15 to 17 people every month. These are small numbers of people compared to our total population of 7,000 offenders, but they're extremely expensive. Subsequently, these folks need follow-up when they come out of our system. We have a great relationship with Christiana and their infectious disease program that we can actually make an appointment before the offender leaves. They have a stated appointment, and for the most part, for our HIV population, they do very well in being followed up. But what we don't have are follow-ups for the people who have the garden type variety, high blood pressure, diabetes, heart disease, follow-up for their chemotherapy after they leave our services. Now, one of the interesting points is when a person is finished with their sentence, they must be released no later than a day later. It's imperative that we get them to someone for follow-up, because we are legally not allowed to treat them anymore. When somebody leaves our facility, they leave with a 30-day supply of medication, and they leave um, um, with a promise that they will get a Medicaid card soon. Why do I say that? We'll talk about that a little bit further. Delaware is a state that when a individual comes into the prison, their Medicaid is terminated. There are many states that the Medicaid is suspended. They're still on the rolls. But in the state of Delaware, they are terminated. So before they leave, we go through a process of getting them Medicaid cards again. That takes time. So what we do is we give them 30 days worth of medicine with the idea that that gives them a month to get their Medicaid card and to make contact with a primary care provider. Okay? So at the intake screening, we actually start the discharge process. We figure out what are their medical needs going to be. Okay? And granted, sometimes that changes. And granted, sometimes we have a little bit of a difficulty determining what all of the needs are. But at the intake screening, we start the discharge process. And our contractor does an extremely good job in attempting to put all of that information together. It is daunting. There's a lot of information. But they do their best with what they're able to come up with. One of the things that really drives us crazy, and I'm sure that everybody has thoughts about having identity theft. We have a lot of inmates who have multiple Social Security cards, some of which do not belong to their name. Okay, and it is surprisingly difficult to figure out what their real Social Security number is. Because if you don't have a Social Security number correct, they bounce back from services. We just can't figure it out sometimes. So the discharge planning, they work continuously. Some of our folks really involve a lot of services. Some of our folks really require nursing home services by the time they are discharged. We have approximately 12 people who, at this point, will require nursing home placement by the time they are released, and we have started onto the process of getting them all of the paperwork, the approvals to get them into a nursing home. But it starts from the beginning, and it is extremely difficult to do. They also need a great deal of primary care after they leave, not only for their medical services, but for their mental health services. The planning, it's an ongoing assessment and a discharge and reentry plan. Every 30 and 90 days after they are out, we attempt to contact them just to figure out how are they doing. An interesting point from some of our people, they were homeless before they came to us, and they're homeless after they leave us. We had a gentleman, the folks at Christiana, I'm sure are going to remember him. He had active tuberculosis. He was homeless before he came in. We started him on anti-tubercular drugs. His time for release came up. We had to release him by the law, okay? And then we lost contact with him. He was living in an abandoned car somewhere up in Pennsylvania. We spent hours and hours and hours trying to find this guy so that we could ensure that he was getting his TB medicine. Turns out that he wasn't. Turns out that he offended again. Turns out he comes back to us, and we started the whole process all over again. If you will excuse the phrase, luckily, he was with us on a much longer term the second time around, So we were able to get him through his complete anti-tubercular therapy. But this is the kind of issues that we are following all the time. Now, my boss, if he was here, he could give you some much more information about TASK, which I'm a medical guy. He's a psychologist. I cannot talk to TASK, to be honest with you. I don't have that much experience with them. So these are the number of people that we have in the planning stage for release. That's a lot of people. So out of our 7,000 offenders who are in level 4 and level 5, 6,600 of them, almost 6,700 of them, are going through a continuous planning for their release. The rest are people who are life sentenced, who are, there's not much chance that they're going to ever leave our facility. Here's our challenges. The loss of contact, like our fellow who had active TB, who was homeless and living in an abandoned car. No shows for appointments. From what I hear, even those folks who we are able to make an appointment with, only about 40% of them show up for the appointment. Somehow we have to figure out what is it that we're missing? Why are these folks not getting the idea they should show up? Well, I understand that there's an educational, there's a transportation, there are a lot of factors, but that's what we have to break down to figure out why they're not showing up for their appointment. Like I had mentioned earlier, Delaware is a Medicaid termination state. This is one of our biggest problems. We have folks who we give the 30-day supply of medicine. Every so often we get a phone call that, well, I've run out of medicine and I still don't have my Medicaid card. We find a way of getting them another 30 days worth of medicine just so that they aren't lost to follow up. It's a heart-rending process that we're trying to go through just to do the right thing for these folks. But somehow we have to fix this termination business. Our strength, we know that our recidivism rate is very high. It's somewhere in the range of 80%. And it really depends upon which study you look at on what that number is. But whether it's 80% or 70%, 60%, we're still way too high. And part of our problem is that we haven't figured out how to break that cycle. We do know that there are a number of our folks who have substance use disorders, have difficulty readapting to being outside, fall back into their old habits, and commit crimes in order to support their old habits. Somehow we have to break that cycle. And we haven't really figured out what the code is on breaking that cycle, other than trying to get them into services for their mental health problems. We talked about increased investment in resources. As time goes on, we're spending more money on our pharmaceutical costs, which takes away from the money that we can spend for other treatment services. And this is just becoming an ever going out of control cycle. As I say, $1.2 million a month for medication is a lot of money. On average, each one of our offenders is taking 5 different medications. And while we are spending a great deal of work, and our contractor is doing a great deal of work to try and bring that number down, it's still a unsustainable amount. $1.2 million, we just can't sustain that over time. Right? Commitment to rehabilitation. Remember Maslow's hierarchy of needs, and I got to turn back to, I'm not sure what Dr. Richmond was going to go with that particular idea. So in ending, what I'd like to make a point of is that the folks that we have in the incarcerated population are older, they're sicker, with serious diseases such as the hepatitis C, the HIV, the chemotherapy, and what we really need is to have a very solid handoff to the community outside so that they can continue their medical care, continue their mental health care, and don't come back to see us again. With that, can I answer any questions?
Thanks. Again, I want to thank Dr. Carr for coming. I actually feel badly because I fed Dr. Richmond dinner last night, and he ended up very sick this morning. So I take
notice Maslow stuff.
So I think some blame for having to drag him, but I appreciate that this first the education about how things work related to healthcare among our incarcerated populations here. We have time for 2 questions for Dr. Carr. Any questions?
Hello. So my name is Kristen Isaac. I'm an outreach coordinator for Westside Family Healthcare. I just have a question. Have you guys worked to partner with some of your federally qualified health centers in Delaware in order to bring, educate patients about the primary health home that these federally qualified health centers can provide?
We actually have. Part of our problem is we can overwhelm the system very quickly. And the federally qualified centers have always been glad to see our folks. But there's a limit to what they're able to absorb. And what we find is that there are times when they can get in and there are times when they cannot get in. And that's just a manifestation of what the great demand for medical services are. We understand the position that the centers are in also, but our approach is we know that they are trying to meet the need, but they have limitations also.
We have another question.
From a systematic perspective, is it possible for physicians in the community to gain access to the information, to the health information that has been collected on the prisoners so that they can get the optimal care when they're outpatients?
So when I started 4 years ago, we began to implement an electronic health record into the department. As part of the requirements for the electronic health record, we've been trying to build an interface with the Delaware Health Information Network. That has had many problems. When we've been working with them, the DIN folks have said that they wanted to update their software in order to accommodate the summaries that our electronic health record put together. Right? As soon as DIN is able to accept our summaries, they will be out there. One of the issues that we're having is they were quite willing to do our medical summaries, their behavioral health and mental health summaries. They had some additional legal discussions on their software that I don't think have been resolved as yet. So honestly, as soon as DIN is able to accept it, we will have those summaries out for everyone. Okay.
Great. Thank you very much, Dr. Carr. Now we're going to